SHA-accredited, SHA available, SHA, I don't know what. What Kenyans don't know is they are comparing mangoes and oranges. For you to access, the rule is simple.
Just
Register,
registration,
yes,
not paying.
not paying. Private insurances are just trying to catch up. There's no innovation, there's nothing, because there's no one who is doing the thinking on the other end, unfortunately.
Welcome to Willow Health Media. This is Lifeline Dialogues with me, Dr. Mercy Korir. Today, the conversation is still on SHA, the Social Health Authority. We promised you that we will keep tabs on the Social Health Authority rollout, that after a month, we will take stock of what has been happening. And we are lucky to still have the chairman, Dr. Abdi Mohamed, who just before the rollout sat down with us to give us an overview of what was to be expected with the rollout of SHA. Since then, we know the hue and cry that has been there around SHA. That has been going down a little bit, but still there are issues around. Last week, we spoke with Dr. Brian Lishenga, the chairman of the Rural Urban Private Hospital Association, and they raised a lot of issues, and they scored SHA at 47%, which is still an improvement from where they are. So we just want to take stock, Dr. and see how would you rate your performance so far since rolling out on the 1st of October?
Thank you very much. First and foremost, definitely we have had challenges in the rollout. But that doesn't mean that we have a D minus. For me, I would look at and say in every sector, in every aspect of the rollout. So if you look at on the issue of empaneling, we have automatically empaneled anyone who has been licensed by KMPDC. On the issue of contracting, yes, there was a delay in the start, which we first did manual contracts, but by week 3, I think we moved to e-contracting. That now has reduced the contracting time for new facilities from 2 years to an hour. So for me, I don't know what rate you will give that from a 2-year timeline to an hour contracting.
That's excellent, of course.
So there you go. For facilities that had an issue at the beginning, first week, in terms of credentials, one of the biggest challenge we had was the issue of disparities between the MFL code and the KMPDC code. The master facility list, that was a parallel coding, which was run by the Ministry of Health, and then KMPDC, which was the regulator. So that discrepancies created a challenge in terms of issuing the credentials. But I would say that now is in the past. There's no facility that I'm aware which has been contracted that doesn't have a credentials to log in. On the issue of course, the contract I've talked about, the tariffs is a document that's well known, gazetted. So what pre-authorization, previously it used to take even sometimes 2 weeks, 3 weeks, 2 days, 5 days, 5 hours, 6 hours, depending on who you know, what you know. In the first month plus, our record was a turnaround time of 1 hour for approvals for pre-authorizations. Now our average time has moved to 13 hours. That's what I got today. But what we would want to do is even have that reduced further with red line to show delays in pre-authorization, so that when we are doing quality checks, we know which ones have crossed the line, what is the issue, what has happened. The pre-authorization, yes, there is one aspect that we haven't yet addressed, and that is the biometrics, which currently we are using the alternative, which is OTP. I'm hopeful that before the end of this month, the biometric will have been addressed. If that's addressed, then the issue of OTP failure or delays will be a thing of the past. So the biometric is a better and longer solution than the OTP. As we are all aware, OTP is SMS. SMS, anything can happen with the network.
Can go to anything, anyone's phone, actually.
I'm not yet sure whether it goes to other people's phones when you are the one who is being sent for OTP.
So the feedback we've gotten is if I'm registered as a dependent, the OTP goes to the principal member.
Yes.
How sure are you that I am related to that principal member? Could have been a collusion somewhere here, such that whoever has presented may not have any relation actual to the principal member because you don't have that identifier.
The principal members are the ones who are dependents. So when they add the dependents, they add the dependents plus the documents. So if it's your child, you upload the birth certificate. If it's your wife, your husband, you put in their ID number and their phone number. Actually, for spouse, they get a notification that Abdi is adding you as his wife. Is it you?
You say
You
yes
confirm,
or no.
yes, whether you are
Or
whether you are the wife or not, because you have gotten the OTP. So you give the OTP. That's how you are added as a spouse. So yes, the OTP is an issue. We will move to the biometric hopefully soon. Then what else would I say is pending in terms of delays or
before you even go to
yes.
what is pending,
Yes.
in your own audit and assessment,
Yes.
what went wrong?
I think the challenge that we have had is two things, I would say. One, the issue of staff. Because the biggest challenge that we have had is most of our junior staff were not engaged by the senior leadership, especially the CEO, because the expectation is he's the one who is supposed to prepare the team, engage them, inform them, meet with them, plan with them, so that they are in sync and they are aware. So the complaint is most of them were actually in the dark in terms of knowing what's going on. So that was one issue. I think the second issue I would say is the system readiness. And our initial plan was to use both systems. But unfortunately, the earlier system was not put on as expected to be used. So then that also created a big challenge. But as time has gone on over the last few weeks, we managed to address those two gaps. The staff, we are still, most of them are catching up now because they have started receiving proper communication from the headquarters. And this is something that used to happen even when I was a provider on this other side. There used to be a disjointed between headquarters and the branch. So what we have now instructed the acting CEO is to disseminate the information to the branches and the providers and members, including patients, to contact the branch so that there is a feedback mechanism from the ground upwards rather than information just remaining with the headquarters.
Is that the issue? Let me call it change management, especially with the staff. Is that why the former acting CEO had to go home?
That plus many other things.
Because it's in between a transition. It's a delicate period.
Yes.
Isn't that not the time to send home an acting CEO because you're a delicate time? So what are the issues?
It is the best time to make corrections because if you allow certain things to go on, then you will never be able to transition properly. So the board had to make that decision, even if they didn't like it, just because of the issues which were bigger. So it was just choosing which one is the lesser
evil.
Lesser evil to take. No one wishes to fire or to suspend anyone. It's just the way work has to be done. And if you don't set the standards, then it will become a norm. And that's not a culture you want to start inculcating in a new organization. That you are trying to replace an older one so that you can reform and have a new way of doing things. Yes.
Now, over the past few weeks, the public feedback on SHA has either been anger, disgust, misunderstanding, everything negative that you would hope, even when there's any, I was in a meeting where somebody tried to say, they went for a procedure and it was paid for, and people could not hear any of that. How come, if things are working well, how come people are still very bitter, very angry, and everyone is like, this thing is not working, we still don't want it?
So it is, when I used to follow the US politics, someone said that Trump listens to the last person who leaves the office. That's the truth. So the second thing is we Africans and Kenyans are generally an oral society. So things that are written is not...
It takes time.
Things that we read. The joke that I used to hear is Baba has read for us. So it seems we are suffering from similar problem.
Oh, there's no Baba that has read for us this one.
No, this one is the person who is spreading the false narrative is the one who has read for us. So we have listened to that person. So we accept. But there are challenges. But when you ask the people who you will find are saying this is bad or this is wrong, we don't want this, then you ask them, what specifically are you unhappy about? That's the time you realize there's nothing.
But
because they can't.
people have been complaining, Daktari, about the 2.75 without a cap. It's a lot of money. People have been complaining that like if you go to the village where somebody doesn't have access to a smartphone or a cyber cafe, they're not able to complete the registration. These are valid complaints.
No, for those ones I understand, but so you see, those ones now for them in terms of the registration, and this is where I was telling you, the branch and the community health promoters are the ones who we are supposed to be the first line in terms of helping people, and that seems to have not reached the people on the ground for them to understand that you can actually go to the branch or look for a community health promoter to help you with the process, because we understand not everyone has access to smartphone. For the 2.75%, I think that boat has sailed. Yes, that has been debated. It is the only equitable way of paying. Any other formula will just create inequity. It's not progressive in terms of the payment, but it's only fair that it is proportionate. What I mean is, if you look at payee, the payee, the way it's done, is progressive. Yeah. Meaning the people who earn 20-something or 18,000 and below pay nothing. Maybe that would have been a better thing for SHA to adapt. The noise would have even been higher than what we are feeling now. So to not create that kind of unfairness, if you might call it, it's only fair that everyone pays as per their ability, equitably. And that's why it's just a percentage, which is 2.75%. And on this one, it mainly affects the employee. The employer, the net effect is zero, because there's nothing they are paying. They're not
matching it.
Yes. So that, I think that's what now people need to understand. And there is a large group of people, and this is the other challenge. The noise is disproportionate to the people who are paying more. The guys who earn 60% of our contributors from the formal sector have a reduction from what they were paying in NHIF. So the expectation is there will be a lot of celebration.
Why isn't
if you compare 60%
to the 40%?
To the 40%.
But why isn't it there? Because if you look online, the feedback we are getting, it's anger.
It is because the few who are usually on the decision-making table have always made the decision on behalf of the majority who don't come to the table. And that's how the NHIF contribution band was created, that the poor should pay 5% of their salary and the rich should pay 0.017%. So that's why the contribution was capped at 1,700. But there's no one who said, can we start from zero? They said, no, let's start from 500 or 150. But in terms of fixing up,
there was a cap.
There was a cap because the people who are seated on that table, the decision makers, are the ones who are earning most. So there is no way they would have accepted to pay equitably.
So as an authority, what are you doing about the information asymmetry? That there is a group who know, like yourselves, obviously, and a few people who have taken time to look at what you're doing. But there's another larger group which has been fed misinformation, like you say, or haven't understood, or simply don't know. What are you doing about that misinformation asymmetry?
We will see us very soon. In the month of next month,
December.
we will be able to go to each of the villages in this country to just disseminate the information to every county, to every sub-county, work closely with the members of parliament and their constituency officers, work closely, much closer with the CHPs. So you will find, those are some of the reasons why we also made some changes, which we will continue making within the organization, so that these things now move away from Nairobi to the grassroots. Initially, we had to address also the teething operational issues, because also talking to people when things are not working also does not make sense in as much. So we had to balance the two. But now that everything is in order, we are processing the claims for the month of October, which will pay fully before the month of November ends. Similarly, November claims will be paid fully before the December month ends. So that's how we want people to know that we are doing the right thing and we are on the right trajectory.
So is there any payment that has been made to providers from SHA and then from the previous NHIF old
Pending
claims,
bills.
pending bills, yes?
Yes, we have made previous pending bills. For SHA, we are making it this week and next week. Both the primary health care capitation and the social health insurance fund claims that have come to the authority next week. So before the month ends, we would have done and cleared the primary health care for this quarter, which is October, November, December. And we would have paid the October claims.
How much are you talking about?
Close to 5 billion. Yes.
Okay.
So it means there are people who have been served. And that tells you that
So
money.
who is complaining? Who is complaining? Because if you're making claims of this amount, then who is this that is complaining? Because I don't want to believe that, people are complaining for the sake of complaining. You see, where there's smoke, there's fire.
Then
So there must be some valid reasons to those complaints.
Definitely there will be. Even when it was NHIF, there used to be issues, 1 or 2, 3, 4, pre-authorization taking a week, system being down for a day, 2 days, 3 days. You just need to Google headlines to see that there has been issues. But the yardstick that we are being used to be judged is means that we have to be flawless 100%.
Of course, Kenyans are expecting a lot because people are paying a lot to this authority as opposed to before.
People are paying what they are supposed to pay, which is equitable contribution. It's not a lot. It is what you are supposed to pay as per your equitable share. But if you go to facilities, yesterday night I was in KUTRH, and when you ask the head of oncology, She said there is a queue for their pet scan. It's around 50 something thousand per session. That 50 a queue for 2 weeks. The 2 weeks patients, all of them are being paid for by SHA. No one is paying cash. So what does that tell you?
Somebody is benefiting somewhere.
It means patients are getting services. Yes.
So at the end of, by 9th of every month, you should have been able to know how much employers have contributed. It's end of month, some Kenyans have paid. How much has SHIF, the contributory fund, been able to collect in this month? Have you met the targets that you're looking for?
Not yet. There is a lot more. There has been challenges in terms of the reconciliation with the banks. Some banks decided to just receive without putting in the requisite. Yes. So there is a lot of work that's ongoing. There is also a lot of mapping in terms of the different employers to see who was compliant, who was not compliant, who are the ones who are missing. So that's what currently we are working on, to see, is it really the optimal level that we expected? And that can only happen once we are done with the reconciliation.
What were you expecting?
NHIF used to collect 2 billion
per month. So it could have even doubled.
Or even tripled, or times 4, times 5. It can go either way. The only difference is this time round, the administrative cost is 5%.
Maximum.
Yes. So compliance has to be the main agenda of the organization. We don't have the luxury of NHIF where anything that comes in, first charge is your administration, first charge is your other activities, then the balance goes to providers. This one is different.
Providers first.
Providers first.
In essence, patients first.
Patients first. Then you can fix yourself in the 5%. So that's why you will find most of the staff in the previous used to focus on the consumption side. Revenue was not a bother, an issue. So for us now, we have to be a little bit more focused on the revenue side, so that we can also increase our benefits. We can also increase our tariffs, so that we also see what's possible, so that we reduce the out of pocket as much as possible.
Okay. Talking of increasing benefits and tariffs, let's look at specific service points. Let me start with maternity. I spoke with a doctor who works in Pumwani, who's saying women are either paying out of pocket or are suffering from delay in seeking care. So they're seeing a lot more cases of sepsis because people either don't know about SHA or they are afraid of coming to hospital because they may be asked to pay out of pocket, or some are opting to seek for, let me call them traditional birth attendants, but basically just delivering by themselves at home because they don't want the risk of going to hospital and being told, you need to pay. That's obviously not what SHA envisioned. So how are you sorting out access to maternity? And the other day, I was seeing some of the providers, talking about how do we claim for a cesarean section, for example, I don't know, normal delivery. Is it still the information asymmetry, or is there really a problem with maternity?
No, it's just the information asymmetry.
So what's the...
So the challenge is, and the communication at least went out last week on either Thursday or Friday. So maternity is free in level 2 and 3 under the primary healthcare fund. That one you don't need to have paid or not paid. All you need is just to register. That's it. So level 2, 3, it's under the primary healthcare fund. And now we have added level 4 in that same communication. So meaning primary healthcare fund will take care of that. The second thing is for people who go to level 5, 6, mainly patients in, I would say, urban centers. And they can't afford. Those are now the ones who we will be treating as indigents. And what we have done is we have resources to pay for them the premium rather than pay for the event, so that it becomes a cover for the whole family rather than just paying for one event. So that is where now, that's where the communication challenge arises. Yes.
Do people know this? Do the providers know this? Not to turn away.
That's women. Where we have now moved into, in terms of implementation, through the branch, direct to the providers, so that now the providers are engaged regularly by the branch. And the branch have gotten communication from headquarters to also understand what needs to happen. So I think very soon that will be a thing of the past in terms of the issue of maternity. Yes.
What of teenage moms? Because as a teenager, they are minors.
Yes.
So they are most likely dependents under somebody, hoping that somebody has registered. So if a teenage mother comes to register, what do you do about it?
No,
what are providers supposed to do about that?
We are registering them as household, a separate household. Yes.
So just walk me through the process. Yes. Say you are, I'm in hospital X. I'm in hospital X.
Yes.
A teenage mom comes, she's 16.
Yes.
What is the process that I should go through?
So you register the same way, but there is a legal requirement, a letter or something from, I had forgotten, because we had given that direction. So you need a document to complete the registration. And now that is counted as a household, and we pay for a premium rather than pay for the event.
So now, assuming
yes,
this girl
yes
is somewhere remote, it's midnight, labor happens some weird hours of the night. So they have come. So they have no letter. They don't know anything about what you're talking about.
So for those ones, as I have said, level 2, 3, 4, it's primary health care.
But I don't even, I will go to my nearest facility.
Go to anywhere, any of those facilities.
Assuming it's not 2, 3, or 4. It's the one I have shown up in. I'm in labor. I'm a teenager. What do I do?
Level 5, 6 are in urban centers. Yes.
But even in urban centers, we have the urban poor. We have urban poor. And because it's access, urban, it doesn't mean they lack teenage moms.
No, it means now you don't have an issue in terms of accessing the system. In rural areas, you would say the system would be an issue, there will be this. But in urban center, that will not be an issue.
So I'm assuming they have come and I'm a provider.
Yes.
They don't have that letter you're talking about or that document, and
No,
they need care.
And
What
that's
do I do?
That's what I was telling you. The document is what I'm not sure which one it was exactly.
From SHA to the providers.
No, the document that the teenage needs to do or to complete the registration.
Where do they get the document from? A chief? Or is it SHA? Where is it?
That's what I need to find out, then I will let you know. Because it was, as the law says, you need to register with certain documents. A passport, an ID, a refugee alien, a refugee permit. So it was very clearly stated what are the documents. So there was also, I think within the regulation, there's a place where people who don't have any of those, how or what they need to get for them to be. But what we are also doing, which will help us address those last minute things, is register during ANC with a branch. Go to facilities, especially high density facilities that have high volume of delivery. Go to the ANC clinics and start the program of registration. The second thing is, again, work with the CHPs when they visit these households. Pregnant mothers, ask them whether they are registered. Yes. Okay. So that we don't wait for when someone is in stage 1, 2 of labor. Yes.
Okay. Now, on emergency care, the last time we had that conversation, your team was still working on the modalities of that.
Yes.
I've seen providers wondering even how to claim for ambulance, yet under SHA, you said emergency within the first 24 hours is my constitutional right, I should not be denied. But here, the hospitals and the providers are saying, we don't even know how to claim. We wouldn't even know where to start with that. Has this been streamlined?
So two things. On the ambulance side, the previous CEO advertised for ambulance. But the advert went out before the tariff was even determined. And the way the tariff has been determined, there was no space for advertising. There was no space for tender, unfortunately. So that also created unnecessary delay. And it shows how disjointed it was that benefits and tariffs are undergoing public participation, but there's a
tendering process
ongoing for a service that we don't even know how much it will cost. So that's why that got stuck. And I think that tender now has been cancelled. So the way the tariff has been envisioned for ambulance, it's for SHA to set up a call center and onboard ambulances, like the way we have onboarded providers. But being onboarded does not mean that you just go and pick and claim. It's for us to tell you, pick here, pick here, pick here, pick here. Then we know.
Like SHA will be the one dispatching.
Yes. So we know who has served, who has done work, and who we are paying. So that process now has started, and the team are working on it. On the issue of...
Before you even go there, and I mentioned this to you on the call center.
Yes.
When I called the SHA call center. I was on hold for like 20 minutes almost. Then when the lady came on, she didn't even help me. She didn't even know what to do. Like, give me the name, the ID, and, we'll get back to you. Up to now, I'm still waiting for them to get back to me. If, in an emergency, you need a call center that is responsive within seconds, if not minutes.
So the difference with the call center and the one, even that call center, so what we are doing is, number one, we are addressing the issue of the number to call to the people who are responding to. Because what we have seen is most complaints, I would say over 90%, is something to do with the system. So a normal customer care person would not be in a position to check on the system and tell you what your challenge is. So the reason why they asked you is they were forwarding. Then, of course, time
2 weeks
gone,
later.
so nothing. The assumption is you have been served, or
Or
they
I
just
died.
know, or you got help
Or I
elsewhere.
died. Because
So
that's
that-
our lives.
So that was an issue. Now what we are trying to create is a smaller number, and then put in both teams in the same space, the IT guys and the customer care, so that they just do transfer within
The
for them
same
to address, yes, in the same space, so that they can check on the back end what is wrong with your either eligibility or adding dependents, because those are the main complaints. I have paid. So you'll find someone says, I have paid, but they have paid elsewhere to a different pay bill number, not the one we
So the
have.
money is lost.
Exactly. Or they have paid what they felt like.
Not what is in the means testing.
They haven't done even that one. So then they just
Actually,
decided.
people are not doing.
Yes.
They're just assuming the lowest is 300
So-
and paying 3,600.
So someone just decides I'm paying without even asking, where am I paying? What am I paying? So those are, you see, some of the things that a normal customer care person wouldn't be able to answer. So yes, on that one we are addressing, but this other one for ambulance is separate. These are professionals, healthcare workers who understand what needs to happen, what kind of emergency it is, and whether it's something that warrants an ambulance or not. So that is separate, complete call center. The other system
For
we are
emergency
done now.
care now.
Yes, we are done with the module in the IT system. It has the clinical guidelines, the investigations, the disease code, the investigation, and then the treatment. So there is no leeway to bill what you want.
But how do you identify somebody? And I'll ask the same question I had asked last time. Somebody comes to my hospital, it's an unknown African male or whichever unknown person. No ID, no identifiers, nothing. And this person is unconscious, they need my help.
You just proceed. You don't need any identifier.
But how will I?
We have done the system. You don't need, it generates a unique code number. If the person is awake, well and good. If they are not, you proceed. Even if they are awake and they are not registered, it's okay. You still just record the name and the ID number, phone number, if they can speak. But they don't need to have been registered. They don't need to have paid, and they don't need to be even conscious. You just need to show up in an emergency.
Isn't that likely to be taken advantage of?
we will deal with any facility that we find engages in that. That will be the end of it. Yes. And I don't know if you're not working with SHA, what you will be doing. That will be the end of that facility.
Okay.
Yes.
And then primary healthcare, Dr. Lishanga actually in his closing remarks said, if SHA can sort out primary healthcare, then the noise, the hue and cry, the anger will go down, because majority of the people probably need to refill their diabetic medicines, or they have a cold, or somebody who was in the shamba has a small cat they need to be attended to. But if they're not able to go to level 2 and 3 to be attended to, then people will feel like, why am I paying for SHA, yet it's not answering to my basic primary healthcare needs?
I'm not sure what he meant by taken care of, because the assumption when you sign a contract is you are engaged. If you have not signed, I would understand.
But if those that have not signed have no business with you. So let's talk about those who have signed.
So those who have signed should be able to serve patients. Yes.
So where's the problem?
I don't know. That's what I'm wondering. Maybe what he was not communicating.
Is it reimbursements?
Exactly.
Is it so then, are you paying level 2 and 3, both public and private?
He should have told you that ni pesa tunangoja.
So umewalipa, have you paid them?
We are paying them this week. We are paying them this week. Yes.
So again, the complaint with the level 2 and 3s. So let me talk about, first of all, the ones in the private sector. That the 900 capitation is not sufficient. 900 per person per year. And then it's supposed to be weighted per condition that they see.
It's sufficient because previously it was 1,200 for the 6 million Kenyans. Now it's for the 50 million. So the population is
bigger.
Times.
So it's 45 billion.
Yes. So you cannot compare what you are being given. And this is the other problem that I'm having. I know not everyone is a health economist, and not everyone is a health financing expert. But when doctors speak to it, or other people who are in other industries, it's from lack of knowledge. Capitation is one of the provider payment mechanisms. And it's a well-known method of paying providers. So the assumption is you have 100 people or 1,000 people. You are paid for the whole 1,000. But 30 of them will seek services. 970 will never seek services. And that's how it balances. So the money will look too little, but when you have a big population that you're looking after, then not all will come. So the money you get is enough to cater for the few who have shown up. The other method that people are used to, which they are comparing, is fee-for-service. So fee-for-service determines every time someone visits, you pay for the service. And even that one, there are two ways. So fee-for-service could be an open one where you bill everything. You decide and say, you have taken a syringe, 20 shilling. I've given you this, 100. This. At the end of your visit, I tell you you have an itemized 2,500 or 6,000 shilling or 10,000. Now, that's what Kenyans know. So then when they see a figure of 900, they say, how is it not possible? Oh, we go to Nananga hizi hospitali hata hiyo hizi nunua dawa. Yeah, but the mechanism is not the same.
But even the providers are complaining. Who should understand what capitation is?
The providers who know capitation are not complaining. They understand. So what Kenyans don't know is they are comparing mangoes and oranges. So even that fee for service, there's another one called fixed fee for service. Mm-hmm. So as a payer, I can come to you and tell you, when people visit your hospital, each visit, I will pay 2,000, irrespective of what they consume.
Whether it's more or less.
Yes. Mm-hmm. I'll just pay you 2,000.
And I've seen the private insurances almost want to limit that in some of the facilities.
They are trying.
The outpatient, yeah.
They are trying. The private insurances are just trying to catch up. They don't understand. Unfortunately, they are like fund managers. There's no innovation. There's nothing. All these things are things done by NHIF, which they are trying now, because their average outpatient visit for some hospitals is 10,000. Yeah, that's not sustainable.
Yeah, they've been trying to limit that to around 5,000 thereabout, but it becomes difficult.
Because there's no one who is doing the thinking on the other end, unfortunately. So it's just as it goes. So anyway, so that's also another option. So Kenyans just need to understand the provider payment mechanism is not for you. This fixed fee for service, capitation, per diem, what is it called? Global budget. Those ones, you just leave them alone. You go, sir, ask, where can I get service? Will I be co-charged? Will I not be co-charged? Will I get end-to-end? That's what you should be concerned about, not what I am paying to the provider, because that is between payer and the provider to have that discussion and haggle. Yes.
So even when we look at the capitation for the 57 million of us, it should be minimum of 45 billion. The budget had 4 billion. That's less than 10%. So it means still there's a gap somewhere. There are like 90% who are not covered.
If 50 million Kenyans register.
Now we are at what?
14
million.
Yes.
So we're still far from it.
We will continue moving upwards, and the supplementary which is coming. So the thing is, yes, you can have the money in the budget, but if the target is over 3 years, that's the assumption, that in 3 years' time, we will have onboarded almost everyone. Not completely, up to 85% of the population. There will always be 15% that we will not have onboarded.
So is the capitation now for the 14 million who are registered?
Yes.
So it means the other 40 million...
we are waiting. You register. For you to access, the rule is simple.
Just
register,
registration?
Yes.
Not paying?
Not paying. Just register. Yes.
Okay. So we hope then, like I said, we will keep track on this and see. So the pre-authorizations, you said it has improved to an average of 13 hours. Is this for every procedure, every visit, every service that somebody needs?
No.
How is
there are
the
specific procedures that have pre-authorization. Not every procedure and every service. So those ones are the ones now we especially the ones that need human intervention, like these documents and what. But the ones that don't need any of those, it is it takes less than an hour. But where you need for a procedure, it needs a second check. Because the first one, the system does checks this condition have been met. Less than an hour, you get clearance. But they are the ones now that need someone to have a look at it and approve. That is now the one which has gone to an average of 13 hours.
Which is less than
a day. Yes.
Okay. Yes. Now, for the contracted facilities,
yes,
because when we had this conversation with you last time, you said, facilities, yes, have been empaneled by KMPDC, like they've been given the green light, you're free to offer services to Kenyans. But the second layer is they have to opt in to be contracted by SHA under the SHA conditions and say, we're ready to offer services. Is there a way for me as a Kenyan to know that this facility is contracted and these ones are still probably on the wait and see or they don't want? Because the implication is if I go to the facility that is not contracted, I will pay out of pocket, which I'm not willing to.
And then you will say
SHA is not working.
Is not working.
Yes.
Yeah.
So is there a way of is there a way of knowing?
No, we are working on that list on the website and also on the Afya Yangu portal. And that will also be on a mobile app, which is Afya Yangu. So you will be able to see the facilities that are contracted.
What of my grandmother in the village? How will she
know?
So
some of the facilities now, what we are trying to work on is to have signboards that say SHA-accredited facility. Yes.
Isn't that one of the easiest and simplest to do?
Yes.
Because it will be the owners of the facility to put it up.
Yes, but we would want them to do in a certain way so that it's not haphazard. And someone says, SHA-accredited, SHA available, SHA, I don't know what.
So on cancer care, obviously, cancer care is one of, the expensive healthcare services, and it takes longer. Is there anything you're doing as SHA? Because now with 14 million lives, you have a bargaining power. Is there anything you're doing or that SHA can do to lessen the burden of cancer care, particularly when it comes to chemotherapy, because some of these drugs are quite costly?
Yes, we have started negotiating with a manufacturer, and we are hopeful that we will get in one of the drugs a price reduction of almost 90,000 from one. So it's something that we are really working very hard on to see how we are able to have a sit down with the different manufacturers and reduce the cost of medicine. So yes, and we'll announce that soon. Yes.
What of screening? Because obviously, if you are going to catch it early, then it means it's lesser burden to the healthcare system because it's lesser cost to treat or to, manage at that point.
So the screening that we have put in place is for the four main cancers in the country.
The top
four. So cervical cancer, breast cancer, prostate and colon. And those are the commonest that we have around. And they are part and parcel of our PHC screening program. So yes, that is the idea. in terms of catching the disease early, which makes it less costly to treat and better quality of life for the patients as well.
Okay.
Yes.
So as we conclude, between now and December 31st, what would you say are your top priorities or deliverables for SHA to give the public hope that you're doing something? Because yes, from this discussion you're doing something, but like I said, the public sentiment is like, no, this thing is not working. So between now and December 31st, what are your priorities?
So priority is to spread the information to the local, to the villages, so that people understand exactly what SHA is all about. Secondly is to make sure when we are in December, we have cleared the SHA bills for October, November. Third is to operationalize the emergency services across the country. Fourth is also to try and operationalize the ambulance services by December. So those are the main targets, in my opinion, and to onboard as many more Kenyans as possible, especially from the self-employed and the groups, the border riders, the farmers, the different cooperatives where people have those groups. That for me is the main. And then once we move into the new year and we get the supplementary budget, is to clear the NHIF debts. Yes.
Okay. We shall keep tabs on it and we'll call you back. Hopefully you come so that, we see if you have talked to people. You said we are an oral society, so people will expect you on ground, and hopefully the information asymmetry will lessen. There'll be a bit more balance. Of course, the bills will get to hear from the healthcare providers. Emergency, we will test it like the way we've been doing, randomly calling your call center. We'll be able to test and check and give you the feedback and see if it's working. So thank you so much, Dr. Abdi, Chairman of the Social Health Authority. Thank you for your time, and thank you for always being available to, be able to give Kenyans some answers to some of the very many questions that they have in regards to SHA.
Thank you very much.
Thank you.